Okay, so you're working a full arrest when someone on the team goes, "Hey, I got a pulse." Whoa, 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 hold up, Sparkles. It's great we have a pulse, but there's still a bunch of stuff we have to do to help make sure at the end of the day, this guy goes home. Okay, so your patient has achieved ROSC, a return of spontaneous circulation. First thing we want to ensure is adequate oxygenation and ventilation. Air going in, air coming out. Two separate things with separate functions that require different pieces of equipment to monitor. First, the oxygenation. That's the air going in. We're going to monitor that with our SpO₂, and we're going to titrate the oxygen, the amount of oxygen, the FiO2 we're administering the patient to achieve a reading between 94 and 99%. Why did I say 99? Studies have shown that a blood gas PO2 after a cardiac arrest greater than 350 was associated with poor outcomes. Now that PO2 is the partial pressure of the oxygen in the arterial bloodstream, right? We can kind of figure that out because a predicted PO2 should be about 5 times the FiO2, right? So a normal PO2 is between 80 and 100. Room air, the FiO2 in room air is 21%. 20, 40, 60, 80, 100. So a normal PO2 is between 80 and 100. If I administer 100% oxygen to this patient, my predicted PO2 on a blood gas is 500. That's over the 350. So by limiting our SpO2 to 99%, at least we know we haven't shot way past that. It's kind of like a speedometer that only goes to 80 miles an hour. Once you're driving faster than 80 miles an hour, you have no idea how fast you're going. Once you go past 100 on a pulse oximeter, you have no idea what their PO2 is. So, follow your local protocols as far as oxygen administration post-cardiac arrest, but we do know that we need to start throttling that oxygen back. We need to reduce that FiO2 because oxygen toxicity is a real thing and it is definitely not good for our patient. Next, ventilation. That's the air coming out of the patient. And what we're really looking at here is the amount of exhaled CO2. We're going to monitor that with our end tidal. Now, the literature says bag the patient 10 times a minute. I hear this all the time. No. Start bagging the patient at 10 times a minute, then titrate your bagging, adjust the rate to achieve an end tidal between 35 and 40. The reason we start at 10 is so that we don't just start bagging the snot out of the patient, hyperventilate them, increase their intrathoracic pressure, and reduce the blood return to the heart. So we start at 10, then titrate our bagging, adjust it to achieve an end tidal between 35 and 40. Next, you want to treat hypotension. You do not want a hypotensive patient. There's 2 ways to get their blood pressure up: fluids or drugs. Always fluids before drugs. Now, the literature states you can give 1 to 2 liters of normal saline. That's fine. This does not mean you're going to hook 2 liters up to a rapid infuser and dump it into grandma. You're going to give them boluses of fluid, reassess, boluses, reassess. And during the reassessment, anytime you're pumping fluid into a patient, emphasis on lung sounds. We do not want this patient to develop pulmonary edema. So as you're giving the fluids to raise the pressure, emphasis on listening to those lung sounds. Watch for crackles developing. Now, if this happens, or the fluids aren't working, we can look at drugs. We got a few we can pick from. Dopamine is a commonly used drug. And generally, we'll start our infusion at 5 micrograms per kilogram per minute. We can also use epinephrine, 0.1 to 0.5 micrograms per kilogram per minute. Or the literature also states between 7 and 35 mics per minute, not weight-based. So, fluids first, assessing for lung sounds always. If that doesn't work, we can look at medications. Now, it's important to remember that the cardiac arrest was never the problem. The cardiac arrest was the consequence of the problem. So we have to figure out, why did this patient cardiac arrest? And you can go through your H's and T's. However, the first one you're going to look at is the heart. Get a 12 lead. Is this patient having an AMI? And if that's the case, we got to toot sweet get this patient to the cath lab. So, why did they arrest? Rule out an MI first, then go through your H's and T's if that's not the cause. Okay, the last item in the algorithm is assessing the patient's neurostatus. And we're going to do this by assessing the patient's ability to follow commands. Now you're probably thinking, geez, the guy's intubated, he can't speak. Doesn't have to speak, has to follow commands. So you ask the patient, hey, move your right hand. He moves his right hand. Wiggle your left foot. He wiggles his left foot. Think you can swipe your credit card through this? Looks like we lost him again. Can the patient follow commands? If he can, groovy. If not, the only thing shown to improve neuro outcomes post-cardiac arrest is targeted temperature management. And our goal here is to reduce the patient's body temperature to between 32 and 36 degrees Celsius for at least 24 hours. Now, nobody knows exactly what those numbers should be, but they're working on it. It's a good starting place. Also important, you have to take that patient to a facility that can actually do this. They should have advanced critical care, cardiac care, and have the ability to reduce the patient's body temperature, monitor them, then rewarm them. So you're probably not going to take him to Bob's Hospital in the middle of nowhere. He needs to go to the appropriate facility. So this has been a quick review of the immediate post-cardiac arrest care algorithm, the 2015 update. I'm Mark, thanks for watching. See you in the next video.